You are about to take the module on airway management and assisted ventilation, your fifth module for the Advanced Cardiac Life Support Training course of the Philippine Heart Association. At the end of this module, you are expected to know how to manage the airway and to deliver assisted ventilation during cardiopulmonary resuscitation. This module will deal with the following topics. We begin with the airway adjuncts. Opening the airway is initially done using manual maneuvers, such as the head tilt chin lift maneuver or jaw thrust without head extension. After opening the airway, you need to maintain airway patency that can be achieved by using airway adjuncts. Airway adjuncts used during CPR include the oropharyngeal airway and nasopharyngeal airway. Let's first talk about the oropharyngeal airway. The oropharyngeal airway helps keep the tongue from occluding the airway. Because of the discomfort during its insertion, this device is often used in unconscious victims who do not have cough or gag reflexes, as what happens during a cardiac arrest. Caution must be exercised in its insertion, as incorrect placement can push the tongue back, further compromising the airway. In patients in whom placement of an oropharyngeal airway is not possible, a nasopharyngeal airway may be a more feasible alternative. However, the use of these airway adjuncts is not recommended in patients with suspected basal skull fractures, as there have been reports of inadvertent intracranial placement of a nasopharyngeal airway in such patients. Next, we'll be showing videos of how to insert an oropharyngeal and a nasopharyngeal airway.
Oropharyngeal and nasopharyngeal airways are airway adjuncts that can be used as a temporary measure to help maintain patient airways that are currently obstructed or at risk of obstruction. Both are available in various sizes, and it is important to choose the correct size before trying to insert them. Oropharyngeal airways are measured from the angle of the patient's jaw to the level of their incisors. Ensure you choose the correct size Guedel before using them. To insert the Guedel airway, introduce it into the patient's mouth, with the end of the Guedel pointing up towards the roof of the patient's mouth. Once you advance the Guedel halfway, rotate it through 180 degrees and continue advancing until the plastic base is adjacent to the patient's teeth, or until you meet resistance. In patients who do not tolerate an oropharyngeal airway, or in those who you are unable to use one, you may wish to consider a nasopharyngeal airway instead. Make sure you have the correct size nasopharyngeal airway before you try to insert it. A correctly sized nasopharyngeal airway will fit nicely between the tragus of the patient's ear and the tip of their nose. Once you have selected the right size nasopharyngeal airway, ensure you apply a water-based lubricant before insertion to ease its passage into the nostril. Stand at the head of the bed, holding the MP airway like a pencil, with the bevel pointing towards the septum of the nose. Insert it into the patient's right nostril, as this is often larger than their left. When inserting it, advance it straight back as if you were aiming for your right knee. A small twisting action may help ease the nasopharyngeal airway into the nostril. Advance it up to the plastic base, or until you meet resistance.
Another maneuver that is thought to protect the airway is cricoid pressure. It involves applying pressure over the victim's cricoid cartilage, pushing the trachea posteriorly, and compressing the esophagus against the cervical spine. Cricoid pressure can prevent gastric inflation and reduce the risk of regurgitation and aspiration during bag valve mask ventilation. However, this can also lead to compression of the airway, impeding ventilation. This disadvantage outweighs the potential benefits of this maneuver. Hence, the routine use of cricoid pressure to prevent aspiration in cardiac arrest is not recommended. Next, we'll discuss the different airway devices. Airway devices can be roughly classified as being either a basic airway or an advanced airway. Basic airways are commonly less invasive and simpler to use, while advanced airways are usually more invasive and are more complicated to operate. The prime example of a basic airway is the bag valve mask device. First, I will show you a video on how to perform bag valve mask ventilation.
Bag valve mask ventilation can be done with one person or two. In both cases, successful ventilation depends on three things: a patent airway, an adequate mask seal, and proper ventilation. A patent airway is achieved by inserting an oropharyngeal or nasopharyngeal airway. To do the one-person technique, hold the mask in your dominant hand. The web space between your thumb and index finger should be wrapped around the connector stem. Lower the mask onto the patient's face. First place the nasal portion of the mask over the nose, and then lower the body over the patient's mouth. The bridge of the nose, the two malar eminences, and the mandibular alveolar ridge must be covered by the mask in order to achieve a proper seal. Make sure you do not place your hands or the mask on the patient's eyes. Doing so may damage the eyes or cause a vagal reaction. Place your middle, ring, and little fingers under the patient's mandible and pull it upwards into the mask. This maneuver is similar to that of the head tilt chin lift technique, and it further opens the airway. While these fingers maintain upward traction on the mandible, the thumb and index finger hold the mask tightly to the face and ensure a proper mask seal. If your hands are large enough, your little finger may be placed behind the mandible and do a jaw thrust maneuver to further open the airway. Be sure to pull up only on the bony parts of the mandible. Pressure to the soft tissues of the neck may obstruct the airway. Once a good seal has been achieved, begin to ventilate the patient. In most cases, the ventilatory rate should not exceed 10 to 12 breaths per minute. Use a tidal volume just large enough to cause the chest to rise. Two-person bag mask ventilation is easier and more effective than the one-person method and should be done if possible. In this technique, one clinician maintains a proper mask seal while the second clinician squeezes the bag. The more experienced clinician should handle the mask because this is the most difficult part. The first clinician holds the mask in a fashion similar to the one-person technique. The web spaces of the thumbs and the index fingers are placed adjacent to the connector stem, and the mask is lowered onto the patient's face, nasal portion first. The middle, ring, and little fingers are placed under the mandible and pull it upwards. The thumbs and index fingers hold pressure along the superior and inferior portions of the mask. Once a proper seal is achieved, the second clinician attaches the bag to the mask and begins ventilation. Note that the first clinician may provide a head tilt and a jaw thrust maneuver while holding the mask onto the patient's face. Observe for proper chest rise during ventilations. An alternative method can be used in which the stronger thenar eminences hold the mask to the face. The first clinician puts the base of his thumbs parallel to each other along the lateral edges of the mask. The mask is then lowered onto the face, and the fingers are placed under the mandible. The mask is pressed to the face with the thenar eminences while the fingers pull the mandible upwards. Chin lift and jaw thrust may be applied concurrently. This technique is easier to perform, allows the use of stronger hand muscles to maintain a proper seal, which minimizes fatigue, and enables 4 fingers rather than 3 to do the chin lift and jaw thrust.
Moving on to advanced airways, the one we are probably most familiar with would be the endotracheal tube. And a less commonly used group of advanced airways include the supraglottic airways. These include the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Next, we'll be showing videos on how to insert and operate various advanced airways.
Raise the height of the bed to allow for a comfortable assessment of the airway by the provider. Align the ear canal with the sternal notch. Place the patient in a sniffing position by slightly extending the neck. Scissor the mouth widely open with the right thumb and index finger. Holding the laryngoscopy blade in the left hand, insert the tip of the blade at the right corner of the mouth. Advance the blade along the lingual surface of the right mandibular molar teeth. Sweep the tongue to the left side of the mouth. Use caution when advancing the laryngoscope blade to prevent injury to the teeth and to prevent entrapment of the lip or tongue. With the curved blade, advance while identifying structures until the tip of the blade is in the vallecula. Then lift the handle to expose the glottis. Insert the endotracheal tube into the glottic opening and through the vocal cords. Inflate the cuff and confirm placement.
Here's an LMA. Take a look at the tube portion, and it's going to show you the weight of the patient right there, the amount of air needed to inflate the mask, and the corresponding size. This is a number 4, which works well for most adults. To insert it, first you're going to deflate the mask, and then it helps if you get some lubrication on the back of it. And for insertion, you're going to slide it first along the hard palate, the soft palate, and advancing it into the hypopharynx. There we go. And now we can inflate the mask, and we can bag our patient. Let's take a more close-up look. The tip of the LMA is going to occlude the esophagus, and that puts the opening right over the glottis, so when you ventilate, air goes right into the trachea. This is the King LT supraglottic airway, and this one's a size 4, works well for large adults. A size 3 works well for smaller adults. To insert it, lift up the chin and the tongue, or if you prefer, you can use a laryngoscope. Now, when you pick up the King LT, pick it up from the connector, and you're going to insert it using a lateral approach until you get past the tongue, and then bring it to midline. Insert it until the connector is at the teeth. And you're going to inflate it with 60 cc's of air. It's a lot of air, 60 cc's. Now you should be able to bag your patient. If you have any resistance to bagging, you want to back it out just a little bit till you get the ventilatory openings right at the glottis. Now there are 2 balloons. The more distal balloon goes into the esophagus. It's an esophageal intubation. And the more proximal balloon, which goes in the hypopharynx. There's 2 main ventilatory outlets, and there are 2 side eyelets, one on each side. There's also a gastric port, which is made to be able to pass up to a size 18 French gastric tube right there on the side. Again, this is a blind esophageal intubation. So when you inflate the balloons, one's in the esophagus and the other is in the hypopharynx, which puts the ventilatory outlets right over the glottis.
Now the question is, how should ventilation be delivered during CPR? Do you deliver ventilation through a bag valve mask device, or do you give it with an advanced airway? You can actually use either. Overall, there is no significant difference in the outcomes of resuscitation between patients ventilated using a bag valve mask device and those using an advanced airway. The choice of which airway device to use will largely depend on the condition of the patient, the skill and experience of the rescuer, and the availability of the device. It is important to minimize interruptions during chest compressions. If chest compressions are interrupted by inserting an endotracheal tube, the interruption must be kept to a minimum of less than 10 seconds, after which chest compressions must be immediately resumed. In contrast, insertion of a supraglottic airway should not involve interruptions in chest compressions. Once you have inserted an endotracheal tube, several physical examination findings can help you confirm its correct placement, the best of which is visualization of the tube between the vocal cords during laryngoscopy. During delivery of breaths, you should also observe a symmetric chest wall expansion. No gurgling sounds should be heard on auscultation of the epigastrium, and breath sounds should be appreciated on both lungs with every delivery of ventilation. In addition to clinical assessment, device-based strategies to confirm endotracheal tube placement are also available. The most recommended method is continuous waveform capnography, which allows real-time monitoring of carbon dioxide concentration in the air that flows through the endotracheal tube. When using waveform capnography, an adapter with a sensor is attached between the endotracheal tube and self-inflating bag. This sensor is attached to a monitor which graphically displays the inhaled and exhaled carbon dioxide concentration against time. The peak of this waveform is referred to as the end-tidal carbon dioxide, and its corresponding numerical value is usually also displayed on the monitor. Clinical findings supportive of correct endotracheal tube placement plus an end-tidal carbon dioxide of more than 30 mm mercury further confirms proper tube placement. In the absence of waveform capnography, acceptable alternatives include a non-waveform carbon dioxide detector, such as the calorimetric detector devices, an esophageal detector device, ultrasound, and a chest X-ray. Note that chest X-rays can verify correct vertical positioning of the endotracheal tube, but cannot distinguish between endotracheal and esophageal intubation. On the chest X-ray, you must visualize the trachea and right and left main bronchi, as well as the carina in the middle. The tip of the endotracheal tube ideally rests more than 2 cm above the carina. Next, we will expound on how to ventilate the victim during CPR. First, you will need the right equipment. For adult cardiac arrest victims, a self-inflating bag that can hold approximately 1 to 2 liters of air will be needed. Next, you must deliver ample tidal volume, approximately 6 to 7 ml per kilogram body weight of the victim. But what is a practical way to know if you've already given the adequate volume of breath? On average, a visible chest rise during delivery of breaths may suggest that you have already given an adequate volume of breath. Lastly, you are to deliver each tidal volume over a span of 1 second to approximate the average duration of inspiration. Next, you should learn how often breaths should be given during CPR. To answer this, check first if the patient already has an advanced airway in place. If an advanced airway is already in place, breaths should be given at 1 breath every 6 seconds, or 10 breaths per minute, accompanied by continuous chest compressions. If an advanced airway is not yet in place, 2 breaths should be given after every 30 chest compressions. Remember that these 2 breaths must be given in less than 10 seconds, again, to minimize the duration of interruptions during chest compressions. Delivering too much volume or too frequent breaths is detrimental to the victim's prognosis and should be avoided. Excessive ventilations can lead to gastric inflation and its resultant complications, such as regurgitation and aspiration, and worse, it can decrease cardiac output and survival. Lastly, let's discuss oxygenation during CPR. So how much oxygen are you supposed to give during CPR? You should give the highest possible inspired oxygen concentration. The adverse effects of hyperoxia have not been proven in cardiac arrest victims. Considering physiology, expert consensus still push for giving maximal feasible inspired oxygen concentration during CPR. Now, how should you deliver supplemental oxygenation during CPR? Should it be via passive ventilation or positive pressure ventilation? Most commonly, you should push oxygen-rich air into the airway via positive pressure ventilation. This better mimics the inward movement of air as in during normal inspiration. During CPR, this is commonly done using a self-inflating bag. Therefore, the routine use of passive ventilation techniques during conventional CPR is not recommended. However, there are conditions wherein passive ventilation techniques may be considered. The following must be present for passive ventilation to be considered. First, passive ventilation should be a part of the EMS bundles of care. A bundle of care is a set of 3 to 5 evidence-based interventions which, when performed together, have a better outcome than if performed individually. An example of this is the bundle of care against ventilation-associated pneumonia, made up of 5 elements to help protect against the development of this infection. Next, the cardiac arrest should be a witnessed event and occurs in an out-of-hospital setting. And lastly, the arrest rhythm should be a shockable one. The reason for these conditions is that they define the EMS requirement and the population of cardiac arrest victims who benefited from this technique, based on available studies. In those studies, passive ventilation was done as follows. Positive pressure ventilation was delayed for up to 3 cycles of 200 continuous chest compressions. Airway adjuncts like oropharyngeal airways were employed, and supplemental oxygen was delivered via passive insufflation such as through a non-rebreather mask. In summary, we learned that airway adjuncts can help maintain airway patency during resuscitation, particularly the oropharyngeal and nasopharyngeal airways. We also learned about the different airway devices, both basic and advanced, as well as how to operate each. We learned that qualities of correct ventilation technique, as well as the administration of supplemental oxygenation during ACLS. As supplement material, we will briefly go through some adjustments in the conventional practice of basic and advanced life support during the COVID-19 pandemic. Before even approaching the victim, make sure to don the appropriate personal protective equipment first. If available, place a clear aerosol box over the patient's head before managing the airway. Avoid bag valve mask ventilation, as this is a potential aerosol generating procedure. Instead, consider early advanced airway insertion, preferably an endotracheal tube, and hook the patient to a mechanical ventilator immediately. Lastly, in the event of an unsuccessful advanced airway placement, cover the patient's mouth and nose with a surgical mask and proceed with hands-only CPR. Thank you for listening. You can now proceed to the next module on post-cardiac arrest care.